This is Chapter 4, Recording 2. When we're interviewing patients, sometimes in order to convey compassion or show that we're actually listening and care about them, it's nice to do well-placed, well-timed personal touch. So oftentimes it's going to be the shoulder, the arm, the hand, every once in a while, a lower leg or a foot, kind of depending on the circumstances. Make sure you're cognizant of how and when you're touching your patient, how they react to it. Try and avoid touching the torso, the chest, or the face. These are typically viewed as more intimate areas and can make your patient uncomfortable, which we definitely want to avoid. Interviewing techniques to avoid. We've already talked about providing false assurance or reassurance. You need to be honest with your patients. Giving unsolicited advice. Oftentimes our patients know exactly why they're in the situation that they're in. There are such things as teachable moments to help them prevent further injury or this happening again. However, don't lecture them. Your parents oftentimes think they know best for you. How do you take that? Normally not so well. Try not to ask leading or biased questions. Oftentimes we think we know what our patients are going to say before they actually say it, and so we tend to pick and choose the words that we use when asking questions to kind of lead them to that answer. Try to keep it open as much as possible so that they can tell you their story in their words without you trying to input what you think into it. Talking too much and interrupting, silence is okay. Sometimes your patient just has to do a quick body inventory before they can give you an answer. Sometimes you say, hey, are you having pain anywhere? Or where is the pain that you're having? And they go, hold on, let me see if I'm having pain. I don't even know. I'm so focused in on something else that I guess I really don't know where I'm at. Along with the unsolicited advice or trying to lecture your patient, don't use why questions. Again, they know what got them there. And the worst thing that you can do after you've established trust is make your patient feel attacked or demeaned in any way. You're going to lose that trust very quickly, and it's very hard to gain that trust back once you've lost it. Try not to use an authoritative voice. We often know or think we know what's best for our patient. And when they go against that by refusing, by saying, I don't want that IV, or no, you can't take my blood pressure, is this really necessary? We tend to use an authoritative voice or even an authoritative stance to try to forcibly suggest that they do what we're telling them to do. It doesn't help. That again makes your patient feel attacked, and they tend not to open up to you anymore. Don't speak in professional jargon. You're going to learn a lot of medical terms throughout this course and throughout your career. Patients don't understand that. A lot of times they don't read medical books like we do. So keep it in plain English. Yes, you might not be able to be as concise and efficient, but it's best for the patient overall. Presence of family, friends, and bystanders, they truly may be very valuable when trying to figure out what's going on with the patient. Even if they are well-intentioned, talk to your patient. Let your patient answer. If a bystander or family member is continually interjecting and the patient cannot talk for themselves, you can always ask them to step away. There are two of you. Have your partner pull that family member away to talk with them so that you can talk with the patient one-on-one. Some golden rules. Make sure that you make eye contact at all times. In our culture, typically eye contact is preferable. If you're making your patient uncomfortable, you can always step that down a little bit, but start with eye contact. Make sure that you introduce yourself to your patients and start building that rapport. Ask for their name, not only for documenting purposes, but ask them what they prefer to be called. Or, do you mind if I call you by your first name? Tell them the truth. Use language they can understand. Be careful about what you say about the patient to others, not necessarily for HIPAA reasons, but more so it makes them feel like you don't care what they have to say. Think about when your parents or other people are talking about you in third person in your presence and not including you in the conversation. It tends to be really, really annoying. Your patients feel the same way, but they need to be able to trust you and talk to you and not feel annoyed by you so that you can get the adequate information. Be aware of your body language. We already talked about that. They don't care what you're saying. They care about how you're making them feel and how you are saying it. Speak slowly, clearly, and distinctly. If the patient's hard of hearing, face them so that they can read your lips, especially somebody that has been hard of hearing for a while. They get really, really good at reading lips. Allow the patient time to respond or answer. We've talked about that several times already, and we're going to keep coming back to it. Act and speak in a calm, confident manner. Oftentimes, we get really, really good at faking it till we make it. Like the duck analogy, you need to be calm, cool, collected on the surface because they're looking to you. They believe that you are going to save them, help them, cure them, etc. May not be true, but that's the attitude that we need to portray. So calm and cool on the surface. You can be panicking inside, paddling like heck underneath the water. Your patient should never know, see, or feel that. Communicating with different age groups. So older patients, identifying yourself, presenting yourself as competent, confident, and caring. This can be as simple as making sure that your hair is neatly groomed, making sure that your uniform doesn't look like you just pulled it out of a laundry basket. Your boots are cleaned, maybe not shined, but at least cleaned and blackened, no mud. We understand that things happen throughout a day that is going to dishevel your appearance, but trying to keep that together. Oftentimes with the older patients that we have, we're younger than them, and so they're already a little bit skeptical about what we know. If you walk in looking like a hobo, they are not going to trust you, period. Don't assume that older patients are senile or have dementia or are automatically confused. Oftentimes, it's the physical portion of a patient that deteriorates. The mind is all there. They know what's going on. Yes, every once in a while somebody's confused, somebody has dementia, but that is not the majority. So give them some respect. And if you find that they are not with it, adjust accordingly, but don't start there. You may encounter hostility, irritability, some confusion. That doesn't mean that that's normal behavior for your patient. Oftentimes, their mental incapacities are because of some sort of physical problem. Stroke, low blood sugar, low blood pressure, not getting enough oxygen, which makes them act out of the ordinary. Approach your older patient calmly, slowly. Allow them plenty of time to respond to your questions. They need more than the typical time. Just trying to remember stuff or form words. They do a lot of editing. Older patients tend to think that their problem is just because of aging, and they don't want to be bothersome or worrisome. And so they tend to wait much longer than the average person to call 911. And then they think that they're an inconvenience. So they tend to really think about their answers before they give them, because they're trying to weed through what they think is normal and what they think is the problem. That can be very frustrating, but that's what the majority of them honestly do. Watch for signs of confusion, anxiety, hearing or vision impairment so that you can adjust your assessment style and how you're relating with that patient so that you get the information that you need. They need to be confident that you're in charge and that you're doing what you can to not only take care of them, but to make them comfortable, that you actually care. If you get to a point in your career where you have the ability or lose the ability to be compassionate towards your patients, you may have what we call compassion fatigue, and you might need to take some looks at what's causing that and try and work on yourself, because high stress doesn't always mean that we are capable of giving our all to our patients, even though they deserve it. Older patients often don't feel a lot of pain, deterioration in nerve signals. Their level of pain may not relate to what they're actually going through. If an older patient is in a significant amount of pain, that should be something that sets off a red flag for you. They may not be fully aware of important changes in their body system that's causing them to feel the way that they feel, that makes them more susceptible to injury and illness. They know that they age, they know that their body is quote unquote falling apart, but they don't know why or exactly how. Make sure that you're very, very vigilant for objective changes. Objectives are things that we can measure. So blood pressure, vital trends, things can change very, very quickly. So make sure that you're paying attention. When possible, give them time to pack a few personal items. Keep in mind, though, that the more you allow the patient to bring, the more you are responsible for. Until you document where that was left, who that was given to, that's your responsibility. And if you lose a patient's personal belongings, that's on you. Try and locate hearing aids, glasses, dentures, anything that will help them be able to communicate better. Really helps out, especially if they end up being in the hospital for some time. They don't have family around to bring them those things. So before we were told, leave those things at their house, at the nursing home, because they're extremely important. We don't want them to get lost. But if they can't hear what people are saying when they're asking them questions, they can't read the paperwork or the pamphlets that they're presented with, or, with dentures, they probably can't eat efficiently, or it makes it harder to speak, then they're not going to be able to adequately participate in their own care. Oftentimes, patients worry about the safety of their home, valuable items, pets, etc. If you can contact somebody on the way to the hospital to let them know that the pet is alone and it needs to be taken care of, make sure that you grab keys and lock the door before you leave. And that's with any patient. Just say, hey, can we lock this for you? Where are your keys at? Emergency situations, load and go, priorities. Okay, and that's not generally going to be something that you're going to worry about in the moment. But if you have that extra free time, that's something you can do to go above and beyond to reassure your patient. We will go ahead and take a break here and continue on.